This is our 15th annual Audrey Lamb Community Forum, held in honour of our founder and friend to many people here tonight, Audrey Lamb OAM. It's my very great pleasure to introduce our guest for tonight's Audrey Lamb oration. Simone Strasser is a hepatologist and therefore very well known to those with touchpoints in the viral hep and liver community. Simone is a clinical associate professor of medicine at the Central Clinical School, the University of Sydney, and senior staff specialist in the A.W. Morrow Gastroenterology and Liver Centre and the National Liver Transplant Unit at the Royal Prince Alfred Hospital. In addition, Simone is also the immediate past president of the Gastroenterological Society of Australia, while also holding membership of various international liver-focused committees. Simone has a major clinical and research interest in primary liver cancer, viral hepatitis, non-alcoholic fatty liver disease, advanced liver disease, and liver transplantation. She is the director of the hepatology clinical trials at RPAH, leading clinical trials of new therapies for patients with liver disease and liver cancer. Simone is also a former board member of and a great and value friend to Hepatitis New South Wales. You know it's true, as we are pleased and honoured to welcome Simone back to participate in her fourth Audrey Lamb Community Forum as we pose the question, will COVID eliminate elimination? Simone, it is great to have you back. Thank you so much for joining us. It's always a pleasure.
Thanks so much, Stephen. It's great to be here.
So, Simone, it has been an incredible 20 months and you've been on the front line, dealing not only with COVID, but the ramifications of that, the scaling back of liver services that actually assisted, along with all the other redirection that went on, of services and resources. What was it like? What's it like being on the front line?
Well, you know, everyone working in the health system has had a different role and a different impact through all of this. And it's certainly been interesting times because everyone has had to pivot so incredibly quickly as the situation kept changing in New South Wales, particularly with the most recent Delta surge. So we got sort of a little bit used to it last year, and a lot of plans were put in place last year about what would happen if we had the surge we thought we were going to have last year. And of course, that never happened. And then the sort of things started to relax and we got a little bit more normal. And then, of course, in June, we had the first case, and then by July and August, it was starting to surge. And by September, it was a complete nightmare. And, you know, I can talk about what happened in Royal Prince Alfred Hospital, where I work, where very rapidly we lost multiple wards to being COVID wards, or COVID, what we call COVID pathway wards, that people where they could have had COVID, but we weren't sure, and we had to treat them as though they were COVID. And eventually that took over 4 floors of the hospital, most of half the intensive care or a little bit more, operating theatres, obstetric gynae units, pediatrics, the mental health unit, a lot of COVID exposure and pathways. And biggest of all, a lot of our staff were deployed, and they're still not actually all back. So a lot of in our area, in our hepatitis nursing workforce particularly, were deployed to work in vaccination centres, to work in the RPA virtual hospital, which is our big virtual hospital, which was just getting going before COVID started, but really expanded then. And then elective procedures all got cut. So we've got a huge backlog of elective stuff. And of course, all our consultations all became virtual very quickly rather than face-to-face.
Introduces a whole pile of new challenges for everyone. And I think we're all sick of hearing the word pivot because we've pivoted so much, we're almost pirouetting now all the time. So it's quite the thing. You talked about how wards were taken over and the resultant delays in surgery, particularly elective surgery, was the first thing to go very quickly, obviously, for very good cause, and the profound impact in suddenly telehealth is a whole new thing in itself, and where everyone seems to have gotten behind it. In terms of the diagnosis, the management, the treatment, the care of people with viral hepatitis and liver disease, what has been that impact, both in practical terms, but what's it going to mean for them further down the track? Are we going to have we put people into a less sure health space than they might have been otherwise?
Yeah, I'm certainly worried at the moment of the impacts for the people that we know have viral hepatitis, including those who have been treated with particularly hepatitis C and may have been cured of their hepatitis C, but have advanced liver disease and ongoing risk factors for advanced liver disease. So with metabolic associated fatty liver disease or alcohol related liver disease in conjunction with their now prior hepatitis C, as well as of course our hepatitis B population. But those lifestyle factors, a lot of that got a lot worse, I think, through COVID. And we've got data internationally as well as locally to say that drinking increased, weight gain increased, and care of chronic conditions decreased. So accessing regular blood tests, regular scans, regular monitoring, seeing doctors face-to-face, of course, stopped. So there's that potential for us missing a lot of the cues that we may pick up on when we see people, and mental health consequences of all of this with the lockdowns particularly, and with division of families and lack of access to normal support structures, I think is going to have a long-term impact on people. And of course, we're talking about generally very vulnerable people at the best of times. And a lot of these challenges have made physical health worse, but also mental health worse. Yeah. So it's going to take a while to come through all that, I think.
There already seems to be a concern across the sector and across the networks around those people that may have been just about to get into the process and into the system, and the concern that that delay will really impact how well they can be caught back up and to have their care and their treatment managed in a way that is going to give them the best possible outcomes. Is that your sense as well?
Well, we've certainly got data nationally and in New South Wales to say that testing rates have gone down, again, as they have around the world. And the targets that have been set around elimination for hepatitis C, which we probably weren't going to hit anyway, the data that came out sort of end of 2019, beginning of 2020 already highlighted that we weren't going to meet our targets by 2028 or 2030, probably not till 2032 or 2034 for some of those targets. And they're all going to be pushed out. But that was already happening, I think, a bit before COVID. COVID won't have helped. And the question is, can we get that up despite the effects of COVID? And I'm not sure. It's very difficult to see how we're going to do that. So that's targets around diagnosis. We're not too bad at diagnosis, engagement in treatment, but around the long-term care and the impacts on long-term morbidity and mortality, particularly in people who have had advanced disease at the beginning. And again, those factors that I mentioned earlier, which is the metabolic factors, the lifestyle factors, the weight gain, the diabetes, obesity, alcohol use, mental health, all those other aspects on the care of people with liver disease. The people who have been identified, treated, and in early stage disease and don't get hepatitis reinfection are probably fine. It's more, I think, the people who haven't yet been treated or who have been treated and still have advanced disease and ongoing risk factors for disease. And they're part of the targets. Part of the target for elimination is around reducing mortality. And that target's being pushed out more and more, I think, with these extra stresses.
I was going to say that's really where the problem is going to really come home to roost, isn't it? Isn't those morbidity and mortality targets being pushed further out? And you mentioned about the elimination dates, and of course, New South Wales being the first state is determined to eliminate hepatitis C and hepatitis B by 2028, as opposed to the WHO and Australian government targets of 2030. We've got 7 years. Your sense from what you've said there is that it's going to be a big ask, and we are a bit behind in terms of Hep C. At least we were doing pretty well in New South Wales. We're travelling pretty well in terms of diagnosis. Hep B has been a real problem for everyone across Australia, and is we're well behind where we need to be for that too now, aren't we? So I think most recently, the earliest target we were going to hit would be around about 2046, which is a horrifying thought. The challenges of increasing, of reorienting and ramping up the activity is that, are we going to sort of see the hospital system, the health system generally experienced long COVID in its own response.
Now, the hospitals, the role of the hospitals in the care of people with hepatitis has changed, as you know. So hospitals per se and liver clinics per se are doing very little in terms of routine care of hepatitis C people. Treatment is out in the community. We've got much higher rates of GP prescription, but people are scared to go to their GPs. They're scared to access health centres. They're not having routine appointments with their GP. They're doing telehealth. A lot of the routine stuff might get missed. That conversation around, whether or not there may be risk factors for viral hepatitis going back 30 years probably won't happen through a telehealth consultation. So there's all these opportunities. And with the hepatitis B space, a lot of that does require, again, engagement with primary care. And if those consultations and interactions aren't happening, then the opportunity to test and diagnose is being missed as well. So I think those diagnosis targets are going to be out, but the number of people accessing treatment, I've just, now that we're sort of coming back the last week or so, my number of referrals for myself of people with advanced liver disease with hepatitis B, for instance, I've just got this massive pile of referrals sitting on my desk that I've got to manage to figure out what to do with before Christmas, which I didn't have a month ago because the referrals weren't coming through. And now people are going back to the GPs. All of a sudden there's, picking up on some of the things that should have been happening over the last 4 or 5 months, and all the referrals are happening. The capacity is not there still. We've got our staff still deployed, as I mentioned. And we're going to have challenges just picking up on all that. And GPs are under significant stress still. And there's still, there are still daily cases of COVID out there. So we've got to keep, even though we've got reasonably high and pretty high vaccination rates, we've still got unvaccinated people. We've still got COVID in the community, and we've still got to keep our primary care settings and our community settings and our hospital settings all safe from COVID still, because that's where vulnerable people are who, even if they've been vaccinated, can still get COVID and still get sick potentially, but obviously not as much as if they weren't vaccinated.
Yeah. Must be nice to be popular, hey?
Yeah, certainly popular. And I think we're all seeing the same thing. So my colleagues have all seen the same thing, that all of a sudden there's, a increasing demand, and for the elective stuff that we do, that's all increasing as well. But what I've been concerned about is particularly, again, advanced liver disease. People have been missing their blood tests, missing their ultrasounds, missing their routine appointments. If they're not in my schedule, I don't miss that they're not there. They've got to sort of now come forward if they've been missing appointments to get back on the radar, get re-referred back from GPs, for instance. So again, it's going to be a whole lot of engagement in the health system with a whole bunch of people that are still quite nervous to do that.
Yeah. And again, those key targets around morbidity and mortality are going to slip further away, and potentially exponentially, given that getting them back into the system and operating in a meaningful way is going to be so problematic. So from your perspective, what does the last 18 months and what indeed does the next 18 months mean for us in this space? I mean, based on especially where you mentioned vaccination, where does that fit in it? I mean, here at Hepatitis New South Wales, we did a whole pile of work and put together fact sheets around Hep B and vaccination, Hep C and vaccination. They've been incredibly popular. It's great. That's reassuring, I think. We know people are visiting them. We don't know where they're going with them. So based on what you've heard, you've observed, experienced, what do you think will help us, get back into the groove and moving towards where we should be?
Well, I think in the hepatitis C space that we had movement going towards point of care testing, much more community testing, test and treat type strategies, a lot of which got sidelined by obviously COVID efforts, and a lot of the staff that were taking on those challenges and those efforts again got deployed into COVID. So as this all settles down and we get staff back into those spaces, I would really hope that with a lot of the technology that we've learned out of COVID, and a lot of the same technology applies to other viruses as well as it does for COVID testing, that we can use a lot of those tools for really ramping up very quickly to do quick testing, quick diagnosis, and quick onto treatment, and obviously triage and further assessment as need be. But I think there's a lot to be gained from the last 18 months, and so in terms of how we've learned to use the health system efficiently and effectively and very quickly. And again, that pivot word, and, you know, change how we do things and think creatively. And I think there's a lot of real positives in that. Telehealth has been good. It's been giving access to people outside of major metropolitan areas, access to care in major cities. And I consulted somebody today in Tasmania who's supposed to be here, but they're stuck, you know, and there's people all around New South Wales that we're all consulting on, and we can deliver care to virtually now that we really didn't think about that much going back a couple of years. So I think there's a lot of positives out of this actually that we can take forward, but we've got to now push that into particularly the elimination space and getting to where people are, whether that's in Hep B communities, Indigenous communities, and of course amongst people who are injecting in those communities. And take this forward and really ramp up our diagnosis rate so we can really link people with care.
Are you optimistic in terms of the public, in terms of the punters that we're trying to get to, that this experience of COVID, where they have been given the message, you know, the slightest symptom, even if you think you don't, you think it's just your sinus or your hay fever, do you think that this may be a one silver lining, that people may be more open and to focusing on their health and being more attuned to their health and reaching out a bit? Do you get a sense of that?
Well, I hope so. I think lockdown was very difficult for people, and I think people are very keen to sort of brush that aside and to get back out, get back to regular exercise, to eating better, to getting with friends, and all those positive things that maybe they hadn't been thinking about so actively before. Focusing on symptoms, that might be good if they're, you know, as long as they're not over focusing on, you know, it gets in the way of their well-being. So I don't totally know about that, but I think there's, yeah, exactly. So I think, you know, we need to make sure we're focusing on the right things. I mean, one of the other things that we observed through this particularly was people on chronic medication, say for hepatitis B, too scared to go to their doctor or their pharmacy to pick up prescriptions, and then having severe flares, which you can see in people with hepatitis B when they suddenly stop medications, particularly that got more advanced disease, and needing urgent transplantation even, you know, in the most dramatic of circumstances. We've seen that this year, where, yeah, and that was through fear of accessing healthcare. Now that's all going to be dissipating. I think there are some barriers. There are people who are still unvaccinated for various reasons, and they feel that they can't access healthcare. That's not true. Even if you're unvaccinated, of course, you can always access healthcare, but we strongly recommend that people do get vaccinated for their own protection and that of people around them. That doesn't mean they can't access healthcare. They've just got to follow all the rules. They've got to have COVID swabs if they're accessing hospital facilities, for instance. They've got to wear masks and all the other things that we all know about. But there has been a bit of a thing that, you know, if I'm not vaccinated, that means I've got to stay in my house locked up and I can't go anywhere. And that's not true. But on the other hand, you should get vaccinated. And there's almost nobody that shouldn't be vaccinated.
Yeah, I mean, it's such an amazing achievement with what they've achieved in terms of vaccination and finding the sorts of opportunities to reduce the impact through vaccination. But yeah, certainly a number of people I know, and I'm sure many others have come across, you know, there's this perception that, oh, it happened too quickly, it got approved too quickly, and I suppose, you know, unique times call for unique approaches, but it doesn't necessarily mean that there is any less rigor or safety or any of those sorts of things that we traditionally associate with very long gestation of research and the production of treatments and cures. So, yeah.
Absolutely right. You know, if we could only see a Hep C vaccine come out that quickly, that would be it. I don't think we're any further along with that, but you hope maybe some of the technologies that have been developed around rapidly developing a COVID vaccine will also, you know, pan out and be looked at for hepatitis C, where we desperately need a vaccine, as you know.
Yeah, if we could also get a cure for Hep B, would be great too. Just as quickly, but we'll get there in the end. Simone, we'll start wrapping up. There's been a lot there, and there's a lot of takeaways. But if there was one golden nugget that you believe that needs to be shared, and it needs to be amplified for everyone to hear, be it government, be it community, be it the New South Wales public, what is it for you?
So I've been thinking about this all afternoon. I've actually changed what I was going to say a little bit. I'm actually, because I'm a liver specialist, that I see that liver disease is usually not due to one thing. And so there can be a lot of focus, particularly from health departments and others, that we need to treat hepatitis C, we'll treat the hepatitis C that's cured, that's it, end of story. But in fact, liver disease is so commonly not just about that. And we have to deal with every single one of the factors that are contributing to liver disease in any individual person. And the big ones are really metabolic related liver disease, which is obesity and diabetes, which is all, such in epidemic proportions and rapidly rising around the country, as well as alcohol. And again, alcohol has escalated through COVID as well. If we don't tackle alcohol use disorders, if we don't tackle the obesity epidemic and the diabetes epidemic, we're still going to have a lot of liver disease in the community, even if we achieve our hepatitis C elimination. We've got to, no question, we've got to do that. We've got to get hepatitis B treated and the risk associated just with the hepatitis B down. But if we don't do all of it, we're still going to have a huge burden of liver disease in people who have had viral hepatitis that's been cured or managed. So mine is really that we've got to be looking at the whole person, the whole of system, and deal with all those problems, and not just pick out the virus to say, oh, well, haven't we done a great job and it's all over.
It's a really good point, isn't it? Is that we still to this day aren't really taking into account that whole of person assessment and looking at all the factors that are there. It's something that's very much inbuilt and part of, for example, the First Nations community, their sense of well-being is the whole person, physical, mental, and relationship health as well. And we can do the clinical stuff. We can pick off the diseases, as you say, individually as cures or treatments come through. But it is only just one part of the whole person, isn't it?
Oh, I think that's right. So we look at it a few different ways. So if you just look at liver tests abnormalities, it's pretty common in the more severe forms of COVID to get abnormal liver function or blood tests, probably as part of the big spectrum. And when somebody's really sick and they've got COVID pneumonia and other health issues, heart disease and all the rest that goes with COVID. So that's one thing. I think it's more the other way in what's the impact of COVID on people who have liver disease already. And we know if you've got cirrhosis, and particularly more advanced cirrhosis, that mortality from COVID is actually very, very high. So people with cirrhosis who are admitted to hospital with COVID and develop severe COVID, the mortality rate's around a third. So most of the figures are consistently between 30 and 35% mortality. So that's huge. And that those deaths are largely actually from the pneumonia, but about a quarter of them are from liver failure and pushing into decompensated liver disease and liver failure. So it's really, really important that we protect particularly people who are living with more advanced disease by vaccination and protect against severe COVID, because the outcomes are much worse. People with viral hepatitis who don't have severe liver disease have got probably the same risks of particularly severe COVID and pneumonia as other people living in the community. And those risks relate to age and comorbidity, which is largely diabetes, hypertension, obesity, and those other comorbidities. Well, they're not being targeted through those strategies that are focused on current injecting drug users, no. So we do have to have a multi-pronged approach to make people aware of what are the risk factors for any viral hepatitis, and if you've got those risk factors to be tested. But you're right, I mean, a strategy that's just focused on current injecting drug users will reduce the ongoing transmission and the incident rates, but we're still seeing, despite that, about 3,500 people a year with new incident hepatitis C nationally. despite all those efforts that we're getting. So we're still not quite there, but we haven't picked up all the prevalent cases either. So people who have been living with hepatitis C for 30 years and have no idea they've got it. And we still see people who get diagnosed at the same time as they develop liver failure or liver cancer. So there were missed opportunities there to get that messaging out, I think. I agree. Well, I'm just talking about 2021, which is the big surge recently. So our numbers for the year will be down a little bit. We never stopped transplanting. Every time there was a donor offer, we would just call ICU first, make sure there was capacity to take somebody who was post-op. And if there was, and I think there always was, I don't think we were ever declined a bed if we had a donor. So we've been transplanting right through it, although the number of donors dropped. As you can imagine, as ICUs filled up with people with COVID, then other care dropped and people were presenting late with strokes and other incidents. Car accidents are down. You know, there's a lot of reasons why there were fewer donors, but our access to intensive care was maintained, fortunately, throughout, and we've been transplanting throughout. But our overall numbers for the year will probably be about 15% down. Not huge, but a bit lower than we'd like to be, and we'll hope for next year that's going to resurge again. But you know, it was stressful. We try and ensure everybody on the waiting list has been vaccinated for COVID. You know, bringing people in while we've got COVID testing protocols and having to wait for tests to come back and all the rest of it. It's all been stressful, and everybody's, you know, the whole thing's been very stressful and anxiety prone year. But we've still been transplanting, fortunately.
Simone, thank you so much for your time. Thank you for your wonderful insights. It is always a pleasure, and we are very, very grateful for your ongoing friendship and support. Thank you so much.
Thank you, Stephen. Thanks, everyone, for the opportunity to talk again.